vitamin D is not only a substance that is a hormone that does many different things in the body. I supplement with vitamin D, and I think it's important to do so. But it's something other than just something that's made by the sun. It's also a marker of sunlight exposure. And that, I think, is the real key. And why is that the key? It's because not only is ultraviolet B light hitting you, making the vitamin D, but remember, those people that are getting ultraviolet B light to make vitamin D are also getting visible light. And they're also getting, let's flip to the other side of the spectrum, infrared light. And this is really the thing that I'd like to spend a lot of time talking about, because I think this is really an area that we have missed out on.
Hello, everyone, and welcome to the Friendly Pharmacy 5 podcast. I'm your host, Lindsay Dixon. In today's episode, we are honored to have Dr. Roger Seheult as our guest. Dr. Seheult is a quadruple board-certified physician, distinguished educator, and the co-founder of Medcram.com. In this episode, you will learn about the latest evidence regarding the impact of light on various aspects of health and well-being, and how near-infrared light in particular influences our metabolism at the cellular level. Dr. Seheult also shares his first-hand experience using light exposure in patient care, shedding light on its potential as a crucial public health intervention. Dr. Seheult is board certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine by the American Board of Internal Medicine. He currently serves as an associate clinical professor at the University of California, Riverside School of Medicine, and an assistant clinical professor at the School of Medicine and Allied Health at Loma Linda University. Based in Beaumont, California, Dr. Seheult practices as a critical care physician, pulmonologist, and sleep physician at Optum, California. Dr. Seheult also serves as the director of a sleep lab and is the medical director for the Crafton Hills College Respiratory Care Program. In 2012, Dr. Seheult, alongside Kyle Allred, founded Medcram, a prominent medical education company known for its continuing medical education accredited videos utilized by hospitals, medical schools, and healthcare professionals globally, boasting over 1 million YouTube subscribers. Recognized for his outstanding contributions, Dr. Seheult has been the recipient of numerous prestigious awards for his work in the areas of clinical practice, education, and public health. Dr. Seheult's passion lies in demystifying medical concepts and making complex topics more accessible. Join us for an enlightening conversation today as we explore the remarkable, evidence-based insights of Dr. Roger Seheult. Welcome to the podcast, Dr. Seheult.
Thank you so much, Lindsay. It's great to be here.
Dr. Seheult, I started following you during the pandemic. Actually, quite early in 2020 is when I learned about the work that you do. I wanted to get back to vitamin D. So you had mentioned that, your thinking on vitamin D has kind of evolved. Now, I'm up here in Canada where we get very little sunlight, especially during the winter. Sometimes we will only have maybe 5 hours of daylight. Different parts of Canada, that goes down to maybe 3 hours during the winter. And so we're quite interested in the topic of vitamin D. And I do take vitamin D during the winter especially. But what are your thoughts now on vitamin D and the importance of this? Obviously, we can get vitamin D through sunlight as well, but when that's challenging, how have your thoughts evolved on vitamin D?
Yeah, so very early on in the pandemic, we saw studies that unequivocally showed that people with higher vitamin D levels had better outcomes with COVID-19. And so the implication being that if we were to somehow give vitamin D to patients with COVID, that their outcomes would match those that had vitamin D levels. The thing that people have to understand is when you do a retrospective study, you simply get an association. And association does not necessarily mean causation. So let me back up a little bit here and talk about, I think the best way to explain how this works is to sort of explain sunlight and start from there. So sunlight is made up of many different types of light. You know that if you put a prism in the sun, you'll see red, orange, yellow, green, blue, indigo, violet, right? That's Roy G. Biv. That's what we all know. But what's interesting is that there are colors that we cannot see beyond violet, and there are colors that we can see beyond, that we cannot see beyond red. Ultraviolet is what we name that, and infrared respectively. This is energy coming from the sun that our eyes are not suitable or suited to actually see, but that light is there. Now, specifically in the ultraviolet spectrum, there is a specific type of ultraviolet light called ultraviolet B light, which is responsible for converting a cholesterol derivative in your skin into vitamin D. This is how we make vitamin D when we go out into the sunlight. It's that particular type of sunlight. Now, what's unfortunate, or maybe fortunate, depending on how you look at it, is that that type of light has a difficult time getting through the atmosphere when the sun is low down. So if you were to look at the amount of light, ultraviolet B light, that's coming through the atmosphere and hitting you, the sun has to be pretty high in the sky for that to occur. This is the reason why you mentioned living in Canada, that because you're at a higher latitude, there's going to be fewer times during the year where that sun is going to be high enough, especially in the wintertime, where that sun is going to be high enough that you're going to get that particular type of light, ultraviolet B light. And so you might need to supplement with vitamin D. Okay. So that being said, you could clearly see, though, that generally speaking, nevertheless, despite the fact that you might not get it all the time, that vitamin D is not only a substance that is a hormone that does many different things in the body. I supplement with vitamin D, and I think it's important to do so. But it's something other than just something that's made by the sun. It's also a marker of sunlight exposure. And that, I think, is the real key. And why is that the key? It's because not only is ultraviolet B light hitting you, making the vitamin D, but remember, those people that are getting ultraviolet B light to make vitamin D are also getting visible light. And they're also getting, let's flip to the other side of the spectrum, infrared light. And this is really the thing that I'd like to spend a lot of time talking about, because I think this is really an area that we have missed out on. Now, on one extreme, ultraviolet light has a difficult time getting through the atmosphere because it's very short wave, and short waves have a very difficult time penetrating through things. But on the other extreme, infrared light, which is that light beyond red that we cannot see, that's coming through the atmosphere, actually has no trouble at all coming through the atmosphere and can come in even when the sun is very low. In fact, you get most of the light coming to you when you are looking at a sunrise or a sunset is in that near infrared spectrum. And just to give you an idea, over 50% of the photons coming from the sun is in the infrared spectrum. So in other words, this is not a small, minuscule portion of the light. This is actually the majority of the photons coming from the sun are in this area. Now, to kind of nail home this point, I'm sure this has happened to you when you're in downtown Vancouver, or yes, when you pull up to a stoplight and there's a car that comes up to you next to you, and it's playing that thing that they call music, but we have a different name for it, maybe. Anyways, some music that has a very low bass, okay? Or when you're sitting in the car, it might sound for them like full spectrum. But what is it that you're hearing in your car? You're hearing preferentially the low frequency sounds. And that is because low frequency energy doesn't have much difficulty penetrating through things that high frequency does. That's exactly the same situation here, is that even you being in Canada, being at a high latitude, and we'll talk about some studies here in a second, but even you being up there, when the sun is low in the sky, the sun is coming up for maybe a few hours a day, and then going back down, I want you to understand this very carefully, is that even though you're not getting enough ultraviolet B light to make vitamin D, you are still getting plenty of near infrared light. And if you might have noticed this, Lindsay, on a winter day when there's snow and the sun comes up, when the sun is hitting that snow, what's happening? It's melting. And as soon as the sun goes down, it stops melting and refreezes. And it may be just a slight change in temperature, but yet such a dramatic change happens. Why is that? Because water preferentially absorbs infrared radiation. And that infrared radiation is melting the snow. And as soon as the sun goes down, it stops melting it. And so here's the proof that you would need, just practically speaking, is that when people who are higher in levels of vitamin D, they're also, if we know that they have high levels of vitamin D, we know for sure that they are getting plenty of near infrared light. Now, Now, let me know. Let me stop there and see if there's any questions about that, or if you want to develop that anymore, because this is a basis of an argument that we're going to make.
Yeah, no, I think that's good. I'm also wondering about the difference between, the light that we're exposed to indoors versus outdoors, right? Because I know you have some things
Yes.
to say about that as well.
Yeah. So as we can talk about that in light of the fact, no pun intended, that we know that 93% of our lives are spent inside. I think it's 87% inside of a home and an additional 6% in a motor vehicle. Now, for those people who live near the city and have long commute times, that might change. It might get worse. But realize that 93% of our lives, this was a study that was done by the EPA back in the 90s. So it's probably even worse now. I mean, back in the 90s, at least the kids would go out and play until the lights turned off, right? And come back in. But now they're on their computers, they're playing video games much more than we used to do back in the 80s or 90s. So the point is that we're inside a lot. And back at that time, back 50 years ago, all of the light bulbs in our homes were incandescent light bulbs. And incandescent light bulbs are the old-fashioned light bulbs that Thomas Edison made and that we basically tweaked a little bit, but still use that technology. Those light bulbs, like the sun, also give off energy in the visible spectrum, but also in a little bit in the ultraviolet, but a lot more in the infrared. So it's giving off light that we cannot see. And that's why those types of bulbs were determined to be very energy inefficient. And that's why there's been such a push, because of the guise of energy efficiency, to change those bulbs out to LED bulbs, which are specifically designed to only give light in the visible spectrum. And as a result of that, they're much more energy efficient. But now we're being exposed to light in the home that is devoid of this near infrared radiation. Same thing with windows. Maybe not so much in cold climates up there in Canada, but here in the United States, especially in the southern region, we cannot afford to have glass on buildings that allow the sunlight to come in and heat up the interior. That may actually be desirable up there in Canada, but down here in the United States, we have something called low E glass, low gain solar low E glass. And what this does is it basically reflects out to the environment the near infrared. So what we've done is we've essentially created an environment inside that is practically devoid of infrared light. And that's really been the issue. So let's back up to the first thing that we talked about, which was vitamin D. Yes, I do believe that vitamin D is beneficial. It is a hormone. It regulates immunity. It regulates bone and calcium metabolism. I take a vitamin D supplement to make sure that I'm getting enough vitamin D. But here's the point. If you believe that taking a vitamin D supplement is going to give you all of the benefits of being in the sun or outside, I've got news for you. It's not, because there is something that is coming from the sun, specifically near infrared radiation, which we'll talk about, that you're not getting inside the home. You're not getting from your vitamin D capsule. You're not getting what you used to be getting from an incandescent light bulb. And in some cases, it's not even coming through your window anymore.
Yeah, and this is something that I think is so important because we really are devoid of this kind of light indoors. And in Canada, we're much more prone to stay indoors because it's warm. And I've heard different people talking about the importance of getting outside, especially in the morning. But I did not know this before listening to you, right? So I thought, what is the point? Today is a very cloudy and cold day. I would much rather stay inside. But could you explain to us a little bit of this near infrared light and how the benefits of this are actually quite profound?
Yeah, so let's start off with a study first that was done back in, I think, 2022. And what they did was they looked at the United States in the wintertime. And specifically, they eliminated all the portions of the United States, probably south of Tennessee, basically, all across the United States, that could get enough vitamin D or could get vitamin D in the wintertime. Just about anybody, I think it's the 34th parallel, I think it is. Anything north of that, there's no way anybody could be getting any vitamin D. And they looked at that period of time in that space north of Tennessee, all across the US. And presumably the same results would have happened if they looked at Canada, obviously, because that's north as well. but they looked at mortality versus latitude. And what they found was that the higher mortality to COVID-19 specifically, the higher in latitude that you went, the increased amount of mortality there was for COVID-19 based on latitude. This had nothing to do with temperature, humidity. This was simply latitude. They said, well, this is really interesting. Let's see if we can take this and validate it in another country. So they went to England. And of course, in England, it was high enough north that they didn't have to exclude any areas because there's no place in England in the wintertime that gets enough ultraviolet B radiation to make vitamin D. And lo and behold, exactly the same relationship held. Higher north, higher mortality in COVID-19. They went to Italy and they did exactly the same study there. And sure enough, again, they found the very same results to the point where the authors of this study published in their conclusion, they said, this is an association study. We can't say whether or not this is causal, but if it is causal, they're saying that exposure to sunlight could prove to be a very valuable public health policy, and it has nothing to do with vitamin D. This is independent of vitamin D. Something is happening with sunlight exposure that has nothing to do with vitamin D that is helping patients. Another study was done where in the autumn of 2020, this is before vaccines, this is before any of our studies really showed of intervention, and they asked this question. They said, when did we see in the countries of Europe, when did we see the surge of COVID-19 take off? And what they did was they looked at temperature, they looked at humidity, and they looked at latitude. When they looked at the date of each surge in each country, and they plotted it against humidity, no correlation was found whatsoever. When they looked at the surge date of each country of Europe and plotted it against temperature, absolutely no correlation. But when they plotted it against latitude, there was an amazing correlation coefficient that was statistically significant. And it was like literally like ticking off numbers off the clock. Finland was the first to get the autumn surge. Then it was Russia. Then it was, and we just basically went down latitude until finally the last country in Europe in the autumn of 2020 to come up with the COVID surge was Greece. So what was happening here as the sun was basically going down in the autumn, the first countries that were put into the shadow, or there was a threshold of somewhat where that light started to disappear, what we found was that those are the countries where COVID started to surge. And so again, this is all suggestive. So where we're going with this is, what is it that this infrared light, what is it doing that is allowing us to have such better outcomes? Okay, so there was for me, it was the groundbreaking publication that basically, no pun intended, allowed me to see the light on this. And I encourage anybody, it's a scientific publication, but it's written at a level that anybody could understand what was going on in the science. And it's a paper by Scott Zimmerman and Russell Ryder. Scott Zimmerman is an optical engineer, and Russell Ryder is the executive editor of Melatonin Research. And this paper was published in his own journal of Melatonin Research. And the title of the paper is The Optics of the Human Body. So this was a paper that had nothing to do with COVID. It was actually, I believe it was published even before COVID. I'm not sure. I have to go back and see exactly. It's a recent paper, though. And basically what they are saying is this. We know that oxidative stress is occurring in the cells, and we know that oxidative stress is involved with a lot of diseases in the United States and in Canada, diseases like diabetes, diseases like high blood pressure, diseases like dementia. And we know that these diseases are risk factors for people with COVID-19. And here's the thing that the paper showed. They showed that melatonin, okay, melatonin, for those of you who know this, is a hormone that we know of that is secreted by the pineal gland in the brain when we're about to go to sleep. It's that hormone of sleepiness. And we can measure it in the blood because it's secreted by a pituitary or pineal gland in the brain that comes on for sleep. That, they are saying, is actually the minority of melatonin in the human body. Okay. And to get into this discussion, we need to talk about cellular biology to understand what's going on. So we are made up of trillions of cells in our body. Uh, Except for the red blood cells in our body, which do not have mitochondria, every single cell in our body has a power station or an engine that runs inside of it that powers the things that our body does. Those little organelles are called mitochondria. And we can talk about the details of how this works, but I want you to imagine in each of our cells of our body, heart cells, liver cells, brain cells, retina cells, skin cells, all of the cells that have nuclei in them have a mitochondria. And these mitochondria are like engines. And just like the engine in your car, the engine in your car is burning gasoline, which is food that we eat, to make locomotion, which is ATP. Okay, ATP is the energy of our body. Well, just like an engine produces heat when it burns fuel to make locomotion, so does the mitochondria make a chemical heat. And just as the heat in an engine, if it is not dealt with, can shut down the engine and prevent the engine from working appropriately, so does the mitochondria create that chemical heat that, if it's not dealt with, can shut down that mitochondria and cause mitochondrial dysfunction. Let me stop there, because mitochondrial dysfunction is becoming this emerging disease that is implicated in so many different areas. When astronauts go into space and they come back, they have an illness. It's a space illness. Science is now showing published papers out of NASA that it can be explained with mitochondrial dysfunction. Diabetes is being shown to be something that is related to mitochondrial dysfunction. Long COVID is being shown to be related to mitochondrial dysfunction. And so this area of research is imperative to understand if we want to crack the code on how to take care of these diseases. So that chemical heat that the mitochondria makes is called reactive oxygen species, or oxidative stress. And that's something that is not all oxidative stress is the enemy. Sometimes we use oxidative stress and it's beneficial, fighting off infections, things of that nature. But when you have oxidative stress in the mitochondria, that is very dangerous. Now, here's the point that Russell Ryder and Scott Zimmerman are making in their paper. They are saying that melatonin, which is probably the most powerful antioxidant known to man. It's even more powerful than glutathione. People talk about glutathione being a powerful antioxidant. Melatonin actually upregulates glutathione. That's how powerful it is. What they are saying is that melatonin is made on site in the mitochondria in orders of magnitude higher than we ever thought conceivable that are being made in the pineal gland. Not only are they saying that, that's that's not that controversial. That's actually well known. And then we have science to show that melatonin is actually being produced in the mitochondria, intracellular, on site, on demand. It's like a cooling system for the mitochondria. But what they are saying in this paper, and what science is starting to demonstrate, is that and catch this now, this is important, that near infrared radiation, yes, that same type of radiation that can penetrate through the atmosphere very easily, can also penetrate through your clothes. This is light that can penetrate through your clothes, penetrate deeply into your skin, and actually get in about 3 to 4 inches into your body, probably 4 or 5 inches into your body, where it scatters all throughout your body. And that infrared radiation somehow, and this is the part that we're not fully clear, we have some theories, we have some data, but somehow it stimulates the mitochondria to make more melatonin, to make more antioxidants, and it helps cool down and keep in check the mitochondria so that they don't become dysfunctional. Removing that light allows the mitochondria to overheat and to become dysfunctional. And so what Scott Zimmerman, Russell Ryder, and many others are saying, and I'm in communication with a professor at the University College in London by the name of Glen Jeffries, who's doing research, which we can talk about, that red light, infrared light, these types of wavelengths of light are extremely beneficial for our mitochondria and may explain the reason why, in the studies that we've just talked about, that people who live at higher latitudes are getting less of that infrared radiation, but it's still there, even in places where there's no vitamin D, and that people who have high levels of vitamin D who were coming into the hospital with COVID were doing better because their high vitamin D levels were simply telling the researchers that these were people that had been exposed to sunlight, including near infrared radiation. So that's kind of it in a nutshell. We could talk about some of the studies and why I think in the details and the molecules that go into this, but think about this as a big picture. Here we are as a society that has gone over the last decade, 100 years, where we're getting less and less infrared light. Look at other societies that are living today who are not as advanced as ours and live inside of buildings and offices, not doing too badly with COVID-19 because they're outside more often. Think about what we're seeing in terms of the studies, how to explain all of these things together. And what you come up with is this idea that getting out into the sun, getting infrared radiation is very beneficial for people with COVID-19, and probably not just COVID-19, other illnesses as well.
I actually lived for about 5 years in Brazil, and I was commenting to my husband the other day that when we lived there, we did not get nearly the amount of sickness that we get now. And when we got it, it was for a very short period of time, whereas it's not unheard of for someone to be sick with a cold here for 10 days or, even 2 weeks, right? And I think that sunlight, I mean, there's obviously a lot of other factors at play, but sunlight, the intensity of the sun and that kind of thing can definitely have something, maybe has something to do with that. Right. I'm also wondering if you could explain this as far as melatonin supplementation goes, because I'm a little bit concerned that people might be hearing this message and thinking that if they just supplement with melatonin, that could be a substitution for, say, natural light. And that's really not what you're talking about here. So can you clarify that for us?
Okay, so think about two pools of melatonin in your body, the intracellular pool of melatonin in your body and the intravascular. So this is the blood melatonin. If I were to measure it in your blood, I would not be seeing it in your cells. So let's talk about the blood first. This is the one that everybody knows about, that knows anything about melatonin. This is the thing that's secreted from the pineal gland. This is what happens when you take a tablet with melatonin in it. It goes into the blood. Okay, there are some people that believe, and it could be true, that some of that serum melatonin might get in and help with the mitochondria, but primarily at night. So here's the situation. You have two phases. You have night and day. During the day, the mitochondria are very active because you're active. Your brain is active. You're moving around. And so the pineal gland is not secreting melatonin. I guarantee you it's not secreting melatonin because any amount of light that hits your eye will shut down melatonin production from the pineal gland. So the mitochondria has to depend on melatonin that is produced on site in the mitochondria for its benefits. You taking a tablet in the middle of the day of melatonin is not going to fulfill that need, number one. Number two, it's going to confuse your body into thinking that it's time to go to sleep. Why? Because the blood concentration of melatonin not only is an antioxidant, it's also a signal to the cells about what time in the circadian clock the time of day is. So taking melatonin not at night will tend to shift your circadian rhythm one way or the other depending on what time you take it. So then the question remains is, if taking melatonin at any other time other than at bedtime is a bad thing to do, what's wrong with me taking huge doses of melatonin at night? First order of business is that melatonin is not a regulated compound in the United States. Lindsay, is it true in Canada? I'm not sure. Is it in Canada regulated or is it over the counter?
Melatonin is regulated in Canada. We usually tell people to look for an NPN number or natural product number. It is available over the counter though, so it is available just for people to purchase.
Okay. So the good news is that melatonin is readily available both in the United States and Canada without a prescription. The bad news is, at least in the United States, is that anybody can put anything into a capsule and say it's melatonin and it's not melatonin. So the first thing that you must do if you're going to purchase melatonin is that you must look on the label to see whether it's been regulated by a third party. Usually the company will voluntarily allow its substances to be tested by a third party. In the US, it's called US Laboratories. They'll have a sticker on there. There's other ones that are just as valid. Generally speaking, if you buy the supplement from a large company, it's usually going to be something that you can depend on. But realize there was a study, at least in the US, where they looked at this, and I think they studied like 4 different supplements, and only one of them actually had the right substance in the amount that was labeled on it. So it's really kind of the what we would call the Wild West here. Okay, so just be careful about that. So, but if you do get something that you feel and you look at and it's legitimate, the next step is the idea with dosing of melatonin can be tricky as well because, and I'm board certified in sleep medicine, so I'm telling you this with some authority, is that when you take a low level amount of melatonin, for instance, 1 to 3 milligrams, that's the type of dose that we would give to somebody who wanted to, let's say, fall asleep better at night, taking it an hour before bedtime. When you start to go up to 10 milligrams, 20 milligrams, that type of a dose, that's getting into a higher dose where it actually may have a paradoxical effect and make you actually more irritated, more less able to go to sleep, more insomniac. So that's the issue with supplementing with melatonin. Bottom line is, I don't have a problem supplementing with melatonin if it's low dose and it's at night and it's for sleep purposes, but you are not, again, going to be able to offset or mitigate the lack of sunlight by supplementing simply with a melatonin capsule at night. It's not going to happen.
Thank you so much for clarifying that, because I didn't want anyone to think that supplementing melatonin necessarily gives you the same benefit. And so you did a great job of explaining that to us. So thank you. I also wanted to know, you mentioned Glen Jeffries. What is Glen Jeffries working on?
Yeah, so Glen Jeffries is a professor. He's actually a professor in the Department of Ophthalmology, and the reason is that he's a retina specialist. He looks at the retina and he does studies on that. The thing that's interesting about the retina, which is that layer at the back of the eye, is that it is the tissue of the body that has the highest concentration of mitochondria. Highest concentration of mitochondria. So what's interesting is that when light comes into your eye, it causes a photochemical reaction in the retina that causes something that requires lots of energy, these budding off of vesicles and these transmission of things in the rods and the cones that finally sense and trigger the transmission of energy and electricity down the optic nerve. So this has to be done so quickly because light is changing so quickly. You have to be able to update very fast. And so you can imagine that there's a lot of mitochondria that are packed in there. What is really fascinating, and Glen Jeffries did a study on this recently, which I'll explain. But imagine that light in the visible spectrum now is coming into the eye, and it is demanding a certain amount of work on the rods and cones. The rods and cones have to deal with this visible spectrum. Before 50 years ago, before 10, 50 years ago, whenever that visible light was coming in, it was always accompanied by near infrared radiation. Okay. And we've just mentioned that there's this ongoing hypothesis that the near infrared radiation is there to supplement and give support to the mitochondria, which are required to produce the energy so that the rods and cones can process the visible spectrum light. Now, what are we seeing? We're seeing a situation where we're inside under LED lights only, where we are now feeding visible light into these rods and cones without any near infrared light. And you can imagine what's going to happen. You have these strained mitochondria that are trying to produce enough energy to deal with the visible spectrum light that the rods and cones have to deal with. Well, wouldn't you know, this is a really interesting study that Glen Jeffries published, and it showed that getting people with poor visual acuity who are in their older years out into, they actually were able to actually quantify this. If they get them outside and expose them to red light, near infrared lights, that their visual acuity actually went up when they were looking at visible objects. Okay, so visual acuity improved when they were submitted to the type of light that would support mitochondrial function. But you know, this this idea is, people could say, well, this isn't a lot of speculation. There's a lot of association. What we would like to see is a randomized controlled trial in people with COVID that got infrared light and those that didn't get infrared light, and see what the outcomes were. Well, it's interesting that I bring that up because I'm leading to some place there. You said you were in Brazil. There was a study that was actually published in Brazil where they did just that. They made a jacket for patients with mild to moderate COVID that had come into the hospital. They were not on ventilators. There was an exclusion criteria that they be a certain age, that they be not overweight. And the inclusion criteria was sick enough to be in the hospital with COVID-19. And they randomized them to a jacket which had built in with them these LED lights that were basically projecting onto the chest, onto the abdomen, and onto the back. And the wavelength specifically was 940 nanometers. This was, of course, in the near infrared spectrum. And they simply put these on all of the patients, and randomly, which they kept track of course, and blindly, they would turn on the jacket versus turning off the jacket. Because this is light that is not visible, the patients were also blinded because they don't know whether the jacket is on or not. And the heat generated from that optical wattage of, I think it was like 4 optical watts, was not enough to be able to feel that. Well, the results were astounding. They were very statistically significant, even though they only had 30 patients in the study. First of all, patients who were given the jacket and had it turned on, those in the intervention group, were discharged from the hospital 4 days earlier than those that were not. And that was despite the fact that the randomization actually caused the intervention group to have a slightly worse, on average, case of COVID-19. Despite that, they were discharged 4 days earlier. They measured hematological function. They measured pulmonary function tests. They measured oxygenation and its improvement. And in all of those situations, those that had the infrared light were superior to those that did not. This was published in a high-impact photo biomodulation journal that has a very high impact factor. And again, peer-reviewed, published, and randomized controlled trial. This is the highest level of evidence that you could possibly have. This was an intervention study, so the confounders are randomized to both sides. The evidence is there. If you want to step back and look epidemiologically, the evidence is there too. Harvard did a study looking back in 2009 when we had the H1N1 pandemic. This was worldwide, and many people don't realize it because it wasn't as severe as COVID. And we had medications to treat influenza. But nevertheless, their study came to the conclusion, and they said this explicitly in the abstract when they published it. They said, we find that sunlight strongly is preventative of getting influenza. And this shouldn't be a surprise to many people. When do we have the flu season? The flu season happens when the sun is the lowest in the sky. This is the same thing that happens in the southern hemisphere, except their flu season is in July, which is their winter. It's when the sun is the lowest in the sky. So multiple studies showing over and over again, I think beyond vitamin D, and probably related to near infrared light, that this is exactly what it is that's going on.
Thank you so much for explaining all of that to us. Now, you were learning all about light and the impact of light, but you didn't just keep this head knowledge. You're actually able to apply this to your clinical practice. So can you tell us about the patient that you were able to help in this way and just share that story with us?
Yes. So it's interesting because a lot of in the chronology of my experience, I was dealing with a lot of patients up front that were very sick, and I was giving them all vitamin D because at that point, I believed that because a lot of the retrospective studies showed that people with vitamin D got better, that we have nothing to lose by giving them vitamin D. I still believe that. I still would give them vitamin D, and I still do give them vitamin D. But it was after the major amount of people coming to the ICU, because I work in the intensive care unit, had gone down. That's when I started to have the time to really look into this. And I came to the conclusion again that it's not necessarily the vitamin D that is making the difference, but it's the source of the vitamin D that's making the difference because there's something else that's associated with it, in this case, near infrared light. But I had nobody to use it on because by that point, the hospitalizations had dropped off dramatically and there really wasn't much. Well, this season, this winter season, there was one patient that had come into the hospital, had been diagnosed actually at another hospital with COVID-19, had been given the regular medications for it, was at that hospital for a reason other than COVID-19, was there for an orthopedic issue, and was discharged home. But in the ensuing 7 to 10 days after he was discharged home, kept getting worse and worse and worse, and now was admitted to our hospital where he had not been before. And he had come in not for the orthopedic issue, but rather for the respiratory issue. By the way, we did a video on this, and I had 100% permission by the patient to talk about this. So he came in, and initially when he came into the hospital, he was on just a couple liters of oxygen through a nasal cannula. So he was admitted to the floor. My job is as a consultant and an ICU physician is to look at patients when they're so sick that they have to come to the ICU. So I wasn't really consulted much at that point. It wasn't until a couple of days later, despite the use of steroids, despite the use of antibiotics, despite the use of all of those things, that the patient's oxygen requirement had got to the point where they were concerned that he may need to be upgraded to the intensive care unit. When I saw him, he was on 35 liters per minute, 100% oxygen. This is a term that we use as high flow oxygen. And it's really the step right before non-invasive ventilation or even intubation. So I was asked to go down and see the patient, went into his room, and he was in one of our isolation rooms, which has a window and has a negative pressure to make sure that the virus stays in the room. When I walked in there, it was dark. The window was closed. The blind was pulled down. The daughter was sitting next to the bedside wearing an N95 mask. The patient was wearing a regular surgical mask. The room just felt depressed, and the patient was depressed. And he was asking me, the types of questions he was asking me were things like, how much time have I got? What's going, these sorts of things. And now realize that, I'm walking into this room with much different mindset that I had a year ago, 6 months ago, when in my mind it was all about vitamin D supplementation and things of that nature. The first thing that I did almost reflexively was open the window and let some light in. But I realized that probably wasn't enough because I remember about windows and how they can block infrared light. And so after talking to him and getting a history and doing all the things that doctors normally do, I walked out of that room determined, and a little voice in my head was like, how can you let him sit in there when you know that the evidence is, and this is after that Brazil study, and I don't have a jacket that I can put on this guy with LEDs on it. How can you let him be in there and stay in there knowing the information that you know? So I immediately went to the charge nurse of the unit and gathered the nurse taking care of that patient and also the respiratory therapist who know me very well. They know that I try things I think outside the box. Back during the pandemic, we were doing hydrotherapy on our patients. That's a different discussion about interferon, which we talked about briefly about. So they know that I'm really someone that thinks outside the box. And I said, is there any way we can get this gentleman into a wheelchair and get him outside? We do this all the time for patients, not get them outside. We get them to a CT scanner. We mobilize them and get them to an MRI scan. We get them and mobilize them and get them to the operating room. We do whatever it is we do because we think that at the other end of that transportation trip, there's something that's going to benefit them. And so in my case, it was no different. And, I'm lucky to work with people that are really interested in getting things done for patients. So my respiratory therapist, my nurse, my charge nurse, they all work together. We jimmied up something where we got two e-tanks. These are oxygen tanks that were able to provide enough oxygen to the patient to keep his saturation above 90. And we were able to get him into a wheelchair. And you'll see this in the video that we made. It's called a case study for sunlight, or a case study for sunlight. We actually got him outside in direct and full sun for 20 to 30 minutes. He's on 100% oxygen, but he's sitting in the sun. We did this. I wrote a prescription in the chart, get this guy outside for 20 to 30 minutes every day. So they went outside, he went home, I went home, came back the next day. I'm driving into work and I'm like, I wonder how that guy is doing. It's that thing where like all of the science, all of the data, all of these things, they're just numbers on a page, but there's nothing better. And I said to myself, even if he's getting worse, it's just one patient. We can't tell, this is not something that is 100% effective. It's not going to cure every disease, but it's something that I think will move the needle. And so in my mind, it would be nice to see if this guy was getting better. Well, I walk in and I ask, how much oxygen is this guy on? And they say he's down to 15 liters oxidizer after one day. So remember now, he was on steroids, he was on antibiotics, and he was on that. And for 2 days of this, he kept getting worse and worse. From the very moment I would say that we got him out into the sun, by the next day, he was 15 liters oxidizer. The next day after that, he was down to 8. After that, down to 5, 4, 2. He was discharged without oxygen about 4 or 5 days later. There was a 100% complete turnaround. And I had never seen, maybe people who take care of patients on the floor see this turnaround. But for me, somebody who was getting worse, getting ready to come to the ICU, getting ready to be intubated, I had never seen, in my experience, someone turn around that quickly. It might have been by chance. Maybe the steroids took 2 to 3 days to kick in. It's just one anecdote. I cannot rest evidence on this case, but it was very interesting to me to see that. A couple of weeks later, when I was making the video, I wanted to make the video. I called him up and I asked him. I said, "Look, we took a picture of you outside. It's from your back. You can't see your face. Is it okay if we publish?" I says, "Absolutely, no problem. You can do that." He told me this. He said, Doc, when you took me outside that first day, and by the way, this guy, he was depressed. So he was a little cantankerous at first, but he lightened up after that. We had to convince him, in other words, to get him outside into the sun. He said, "You know what, Doc, I'll have to tell you that feeling that sun on my chest and just feeling that it just felt so good to get out into that sunlight." And it's sometimes the truth is redundant. The things that we do, if you look at animals that are sick, what do? They go out into the sun. I have plenty of pictures of my cats in the garage. When the light comes through, they pick that area and they sit right there if they're feeling ill or sick. And so, that case. And I published that case and I made that video because and people have across the country sent me in videos of their own showing that, for instance, one nursing home manager showed that during the pandemic, he got all of his, about 6 or 7, it wasn't a big nursing home, but 6 or 7 of his residents out into the sun every single day. He said we never had an issue with COVID that had to send him to the hospital. It was just a small cold and it got better on its own. Again, anecdotal evidence, but it seems to confirm what these studies are showing. And again, there's that randomized controlled trial from Brazil, which I think was very helpful.
Now, I'm wondering if we can loop back a bit into the work of Glen Jeffries and the research that he is doing. Can you explain a little bit more, if we go a little bit deeper into the actual molecular level of what is going on? Can you explain that to us?
Yes. So to understand what's happening at the molecular level, you have to understand the mechanism of how the mitochondria makes energy. And so there's 3 different food sources. There's fats, there's proteins, and there's carbohydrates, and they all funnel in to the mitochondria in its matrix in the center of the mitochondria, where it gets converted into a 2-carbon unit called acetyl-CoA. And so it goes through this thing called the Krebs cycle. And the purpose of the Krebs cycle is to take these carbons that we eat and take the electrons off of those carbons. And those are very high energy electrons. So how do we get energy from these high energy electrons? Well, what it does is it goes through something called the electron transport chain. And the best way that I can describe that is, if you know anything about the Colorado River, you'll know that there are several dams along the Colorado River at various different heights. So as the Colorado River goes from the state of Colorado and goes down into Baja, Mexico, it goes through various dams. There's the Hoover Dam is one of those famous dams, but there's multiple dams. And as the water goes to those dams, it is allowed through and it causes a turbine to turn that creates electricity. And then it goes to the next dam and the next dam. Well, that's something very similar what happens in the mitochondria. These high energy electrons go to these proteins called the electron transport chain. Think of these as like a chain of dams. And as they go through these dams, they push protons into this space around the mitochondria called the intermembrane space. And so as these electrons go down their transport chain, we are pushing protons into this intermembrane space so that there's a high concentration of protons all the way around the mitochondria. Now, we'll get to what happens to that in a second, but realize that at the bottom of this electron transport chain, so when the water of the Colorado dumps into Baja, Mexico, Baja, the Gulf of California there, there's got to be something that accepts this. And so that needs to happen in the mitochondria. And the thing that accepts these very low energy electrons, because they've been stripped of all of the energy, is the molecule oxygen. And this is the reason why we breathe oxygen in. We could not live without oxygen because oxygen is the only molecule that is willing to accept these low energy electrons. Now, it takes about 4 electrons to combine with that oxygen molecule to make water. Okay, and that's exactly what happens. So long as that's happening, no problems. The problem happens because every once in a while, those 4 electrons don't go onto that oxygen molecule perfectly. Sometimes only 3 go on, or sometimes only 2 go on, or sometimes even only 1 of them goes on. And if that happens, you don't get water as a product. You get a superoxide as a product, or a hydrogen peroxide, or a hydroxy radical. Those products, instead of water, are extremely reactive because these have these singlet oxygens or electrons. And these electrons are so reactive that literally the next thing that these molecules bump into, they will change and degrade it. So imagine the mitochondria is making energy, and a byproduct of this energy is that heat. And here's that chemical heat, that reactive oxygen species that we're talking about. And it's making it right inside where the energy is made. And if it damages because it makes too many reactive oxygen species, as the proteins become damaged, guess what happens? They make more. They're less inefficient, and it's more likely to make heat. It's kind of like the piston going up and down. If the piston is going up and down and you can't cool the engine, the metal starts to shrink or starts to swell. And what happens is more heat is made, and as more heat is made, it expands even more. That's the problem with dysfunctional mitochondria, is that dysfunctional mitochondria makes more products that make it more dysfunctional. And that's the issue. So what is imperative is that you have substances there that can mop up those reactive oxygen species, those hydroxy radicals, that hydrogen peroxide, that superoxide. And the body actually does have systems in place to mop that up. Glutathione is one of those systems. Catalase is one of those systems. Superoxide dismutase is another system that's put in there. But the king of all of those systems is the melatonin molecule. The melatonin molecule actually has 4 different sites that are able to mop up those reactive oxygen species, and melatonin upregulates those systems. So it's not fooling around in the mitochondria when the mitochondria is producing melatonin on site to help these things. So the question is how is this near infrared radiation actually doing its business in the mitochondria? So let's back up a little bit more. I talked about how those high energy electrons go down the transport chain, but I said in the process of that, these protons are being pumped into the inner membrane space. Well, this is like the major dam. Okay, so all of these protons are up there. What are you going to do? They want to come back in because there's a high concentration outside. So there's a protein called the FTPase, which as those protons come back into the matrix of the mitochondria down their concentration gradient, there's a protein that then converts ADP to ATP, and that is how you make energy. So there's a lot of theories. The 2 biggest theories right now in the scientific community as to how near infrared light is affecting these changes in the mitochondria is number one, this is one theory, that cytochrome oxidase, which is one of the proteins in the electron transport chain, is actually sensitive to infrared radiation. And when infrared radiation comes through, it turns on a number of systems that allows that system to actually generate melatonin and speed up the systems and generate more energy and actually run more efficiently. That's one theory. And if you think about the enzyme's name, cytochrome oxidase, what does chrome mean? It means color. And it's because they have noticed that cytochrome oxidase does actually have some absorptive color to it. And that's one of the, if something is colorful or has color, it means that it is visually active. It means that it is absorbing light. Okay. All right. So the second theory, which has been looked at, and actually Glen Jeffries has done an experiment which may suggest that this may be the correct theory, although I don't know how rigorous he is about the theory specifically. It is a theory, and it's a very interesting theory, and it says that infrared light. Remember I said at the beginning that infrared light is absorbed by water? Yes. So it's the reason why, by the way, if you look at the solar spectrum of light, that right at around 940 nanometers of light, there's a big drop in transmittance of that light. And it's because when light comes through the atmosphere, the water vapor absorbs that particular wavelength of light. It's the reason why that unfortunately on a cloudy day like it is right now here in Southern California, as I'm telling you this, clouds will absorb a lot of the near infrared light, and it's why it's cooler under clouds, because you're not getting that light. Well, obviously, the mitochondria is filled with water. Our whole bodies are filled with water. There's 70% water. And when that near infrared light comes in, it's a low-grade energy that vibrates. And what this is an interesting theory, but what it's doing is they believe that it may be causing the viscosity of the water around that pump, that FTPase, to become less viscous. They say it's ordering the water structure. By ordering the water structure, the pump is able to pump faster. And because of that, the protons are able to come into the mitochondria faster. It's able to produce more ATP. And as a result of that, the rate limiting step is increased, and metabolism is able to go through at a faster pace. So what's the evidence for this? Well, this was a very fascinating study that Glen Jeffries did and is going to be published very soon out of the University College London, where he took healthy subjects. He had them eat a glucose meal. So glucose is one of those fuels that goes into the mitochondria. And he randomized them to having exposed on their back red light. So this was light that was not in the infrared spectrum, but a little bit more toward the visible spectrum, but in that general area. And what he found was that when subjects were exposed to red light and they didn't know it, their eyes were covered and it was on their back, so they couldn't see if the light was on or off. When they took in a bolus of glucose, this was like a glucose tolerance test, that the spike in glucose that went up in their blood sugar was less, statistically significantly less, when the light was on versus when the light was off. Now, why would that be? It's because when you take in that bolus of glucose, the body is able to metabolize it faster and make energy in ATP so that it doesn't hang around. So the way he tested that theory was to say, okay, well, if that is the case, if the blood glucose is lower because of metabolism, then we should be seeing the products of metabolism. And what is the product of metabolism? Well, if you understand metabolism and the Krebs cycle, you'll know that carbon dioxide comes from glucose, and that is the product of metabolism. So not only did he measure their glucose, not only did he do this red light thing, but he also measured the amount of carbon dioxide coming off of these subjects in simultaneous measurement. And sure enough, in those that got red light, those had higher levels of carbon dioxide than those that had the light off. So this is really quite interesting. What it's showing us, and this feeds into a whole other discussion about circadian rhythm, is that really, if you want to have lower blood glucose levels, that you really should be eating in the presence of light. You should be eating when the sun is up and not when the sun is down. I think it's a fascinating in look not only at the mechanism of the mitochondria and the metabolics, but also just in general how this affects people and what we do in this country in the United States, probably I know also in the Western world, in Canada, in many parts of Europe, is people love to eat late. And that's a whole nother discussion about circadian rhythms and that sort of thing. But anyway, I leave it at that.
And I'd also like to touch on the importance of being out in nature and the role that near infrared light plays in nature, because I think a lot of people are unaware of this, that even on a cloudy day, the forests and people who are exposed to greenery actually do a lot better and have better health outcomes. So could you explain that to us a little bit?
Yeah, no, that's a excellent point. So we have known for decades that epidemiologically, people that live in green spaces, what I mean by green spaces is surrounded by natural green foliage. People who live in those spaces have less diabetes, have better cardiometabolic health, live longer, all of those benefits. But we never understood why. We thought it may have to do with relaxation and less pace, and it may very well be part of that as well. But one thing that we do know very specifically is that chlorophyll in the leaves of trees, grass, plants, specifically are very highly reflective of near infrared light. What does that mean? That means that if you were to go outside on a sunny day, I could show you the spectrum of light that's coming to your eyes. And you would see that there's obviously a lot in the visible spectrum, and there is a moderate amount in the infrared spectrum. But if you were to put trees around you and grass around you, the amount of near infrared light coming to your body would be literally double of what you would be getting without those trees. Why is that? They're like mirrors of light coming down, hitting the trees, reflecting off the trees, and then coming towards you. Two ways to show that this is happening. Number one, just physically think about days where it was hot and you went under a tree. The temperature drops dramatically when you go under a tree. And that's because that a lot of the energy from the sun that creates heat is being reflected away. Think about when you go outside the tree, when you go out in under the canopy, away from the tree. You can close your eyes and close your eyes so that you cannot see any light. You can still feel where the sun is. And why is that? Because that near infrared energy, the way that you are interacting with it, is it's penetrating through your clothes, it's penetrating through your skin, and it's activating the heat receptors in your skin. You can tell where that sun is because of the warmth of that sun that you feel. The other way that you can show this very clearly is just go to Google and type in infrared photography. And this is a type of photography where they put filters on the lens that allows the infrared to show up as an image that we can see because we could not normally see. And if you do that, you will see that grass, leaves, anything that's green lights up like a light bulb. In fact, if you don't look carefully enough, it would look as though snow had fallen on the leaves that day in the middle of the summertime because it's so bright. Well, again, this is starting to explain why that might be. Getting outside into green spaces is so beneficial. We've known this for years. We've known this for centuries, actually. It's one of the reasons why we have Central Park in New York City. It's the reason why we're trying to introduce green spaces into our urban life. It's also the reason, by the way, Lindsay, that we have very strict guidelines from the federal government in terms of education buildings and the allowance in of natural light. There are very strict guidelines that if this is an educational building, especially for children, there needs to be certain requirements for natural light to come into those buildings. And it's not because we've known the science for years, not because we know about the mitochondria and all the things we've just discussed. We just know empirically that students that are in environments with natural light and green spaces tend to do better than those that don't.
Thank you for that. That was fascinating. And so, in terms of chronic disease and mitochondrial dysfunction, do you know if there are any studies right now that are looking at this, say for patients with long COVID or patients with other chronic illnesses where the mitochondrial dysfunction may be one of the factors that are at play?
There actually is there are some studies that are ongoing, although it's more epidemiological. For instance, I published a paper recently, not on long COVID, but on COVID, looking at geography and world populations. It's not strong evidence, but it shows what the trends are. I'm not aware of a interventional randomized controlled trial looking at long COVID and near infrared light in terms of that. However, there are a number of companies that are looking at long COVID and brain fog.
Yeah.
There's a company called Neuronic actually that is producing a helmet that shines infrared light into the brain. Now you might think this is crazy, right? How could this possibly be that you can have a laser? It's gonna just hit the skull and it's gonna bounce right off. Again, this is this is something that people are having a hard time wrapping their minds around, is that near infrared radiation not only penetrates the skin, it also penetrates the skull. They are showing that the cerebral spinal fluid around the brain acts as a diffuser, and that the crevices in the brain called the sulci are able to collect that infrared light down and deep into the crevices. And when you know it, Leslie, is that the gray matter that goes around the brain, that's the stuff that's rich in mitochondria. So it's literally the brain, the way it's set up anatomically, is functioning as a collector of infrared light. So what this device does, it's a helmet, and they're actually able to project light, red light, infrared light into the brain to affect change. And actually, there are doing some studies right now to show, what they're saying is that they are seeing benefits to people with brain fog and things of this nature. We are seeing there's a whole field called photobiomodulation, and there's literally thousands of studies showing that near infrared light benefits in terms of wound healing, benefits in terms of metabolic health, all of these things. I personally, I'm not here to push any particular one device, but what I'm saying is that my preferred device that I like, people ask me which device do I like, and I kind of half joke with them and tongue in cheek. I say, I like the device at the center of our solar system. I think that device is the best device. And to get out, why pay a lot of money for something that you can go out and get for free in the sun? Now, I understand that there are some people that can't get outside in the sun. There are some people that can't get outside or are so sick that they can't do it. And so I'm not against the development of these devices. I think that's amazing. That's great. There are some people that live in places where the sun doesn't come up, or it's cloudy many times of the year. So certainly, these are areas that need to be worked on, and I don't disparage in any way the making of these devices. But if you have the opportunity to get outside in the sun, I think that would be great. You mentioned in terms of long COVID, there's a whole other aspect to the treatment of this that has nothing to do with light, but it does have to do with this idea that when you have a dysfunctional mitochondria, that dysfunction is not going to get better until you replace it. So you need to break down that old mitochondria and allow the body to build up new. And the only way you can really do that is with autophagy, where your body breaks bad things down and builds new things. Now, this has nothing to do with weight loss, right? If the weight of a bad mitochondria is probably exactly the same weight as a good mitochondria, it's just it's quality, not quantity, right? Mm-hmm. So one of the things that we know improves autophagy, that means autophagy is autophagy, literally self-eating. It's where your body breaks down bad things and then builds it back up again. The way to really make sure that happens is intermittent fasting or fasting in general. And that's a whole nother topic. But when I say fasting, they reflexively think, oh, weight loss. It's not about weight loss. In fact, if you do intermittent fasting and don't lose a single pound of weight, you may think it's a waste of time. But in fact, what your body is doing is allowing it the time to break things down. I'll just mention this one point. The way to do that is to signal the body's processes to do autophagy. The way to do that is to have ketone bodies around, or at least not be metabolizing carbohydrates. Well, it takes, from eating to not eating is from you metabolizing carbohydrates to not metabolizing carbohydrates is about 3, 4, 5 hours of time. And so you need that from your last meal, 3 or 4 or 5 hours, to actually start to have that type of metabolism occur. And that type of metabolism occurs best from a circadian rhythm standpoint when you go to sleep. And so I would advocate, and there's been a number of studies that have shown this, that if you're going to do intermittent fasting, the best time to do that would be to eat a good breakfast, eat a good lunch, but then stop eating after about 4 or 5 o'clock, 6 o'clock at night to allow that time for the carbohydrates to be metabolized so that when you're ready to go to bed, you're already starting to go into autophagy mode, breakdown mode. Now, it may not be the same, for instance, as fasting for 3 days or 72 hours. We've seen evidence of that. USC has published on that and what it does to the immune system. I'm not saying that you have to do that, but if you are eating throughout the day, if you're eating when the sun goes down, okay, you're not getting the benefit that we talked about with that study with Glen Jeffrey. You are not allowing the body to do its best at night. Your chances of breaking down this dysfunctional mitochondria and replacing it with new mitochondria is less. And so you can see here, sort of circling back to the very beginning, if somebody came to me and said, I've got long COVID, what should I do? Immediately in my mind, I'm thinking, you've got dysfunctional mitochondria. It's the basis for a lot of the things that you have. What can I do to take those bad mitochondria away, put good mitochondria in there, and make sure that it's sustained well? Number one, it's got to be good sunlight exposure. It's got to be good near infrared radiation. And you got to let your body try to help heal yourself by getting that mitochondria broken down and building back up. And so my recommendation would be early morning sunlight exposure and, intermittent fasting with no food after 5:30. To some people, that without hearing any of this evidence, that might sound a little dismissive, as like, well, how is that going to help me? But you can understand now that we've gone through the evidence and you can see why that would be at least a first place to start before saying what's left over and then going from there. It is challenging. I try to get outside as much as I possibly can. I make it uh, a priority. For instance, when I'm at work and I have to work from 7 a.m. to 7 p.m. in the wintertime, even here in Southern California, um, the sun is not coming up at 7 a.m. So I'm leaving for work before the sun is up, really, and I'm coming home well after the sun goes down. So I try to make it a point that on my lunch break, I take it outside. And I've told everybody I know about this. And so what's funny is at our hospital, we have a little quad in the middle of the hospital where sunlight gets in, and they have limited chairs. And it's becoming harder and harder for me to find a place to sit down because so many other people are joining me in that experience, which of course is a great problem to have. But people notice that they feel like they have more energy in the second half of their day. They're not as depressed. They've gotten some sunlight, and they can actually feel this. We're only talking about 20 to 30 minutes more than you are now can, I think, have a tremendous benefit. Now, I'm not only working in the intensive care unit, I'm not only a sleep specialist, but I'm also a pulmonologist, which means that I get people referred to me from other clinicians for people that are having shortness of breath. And as you know, shortness of breath is a major component of long COVID. So I have collected a number of patients with long COVID over the last year or two. And after learning about this, after understanding about intermittent fasting, understanding about light, my two biggest recommendations for my patients, just off the bat, when I've ruled out all of the other organic issues like blood clots and cardiomyopathies and things that you could get from COVID, when I've ruled all of those out, the first thing that I tell them that we need to start doing is to get outside in the sunshine more, number one, and to try to do this intermittent fasting. So I'll tell you about one patient that I had. He came to me with 8 out of 10 shortness of breath. It was bothering him tremendously, and he didn't know what to do about it. And he had had this for a year. So I explained all the science that we just explained. Of course, I did it in about 15 minutes so that in the clinic visit, he got very excited and it was ready to implement it. And he was very religious about not eating after 5:30 and getting outside into the sunshine. He came back and saw me a month later because I gave him a return appointment. I wanted to see how things were working. And he was just amazed. His shortness of breath went from, after a year of being 8 out of 10, went down to a 3 out of 10. In fact, he says it didn't even bother him as much. He had to think about it for it to bother him. It just went away. He just didn't even notice it anymore. The other thing that he noticed that he didn't know that he had, but that really he noticed this tremendously, is that after he stopped eating after 5:30, his gastroesophageal reflux disease, this is the acid reflux that comes up from the stomach, completely went away. And he was able to get off his medications at night. And this, I believe, allowed him to sleep. There's something that people don't know about gastroesophageal reflux disease. During the day when you're awake and reflux comes up into your esophagus uses peristalsis to bring it back down into the stomach. That does not occur at night when you're sleeping. There is no peristalsis occurring when you're sleeping at night. It goes up and it sits there. And that irritation, that acid, that pain, you may not remember it, but you wake up and there's multiple arousals that occur during the night, and so that you don't sleep very well. So for this gentleman, just doing those two interventions basically got rid of his gastroesophageal reflux disease, probably allowed him to sleep much better, which allowed his rest and repair model to start working better. And the sunlight, the near infrared light, optimized the mitochondria that he had so that when it was repaired, it stayed and worked well. And just after a month, there was a tremendous benefit. That reminds me of another study that I'll just mention here very shortly in terms of sunlight and how fast these things can work. So maybe someone's listening to this and they say, well, I'm going to get out inside in the sun. How soon do I expect to start to see some evidence of change? There was a study that was done at Oxford and in Laden, a city in the Netherlands. And it was not looking at the differences between these two cities because they're at approximately the same latitude, but they just pooled these people together and looked at them, and they drew blood and they looked at a number of different metabolic results. For instance, insulin resistance and triglycerides, cholesterol, all of these sorts of things about how does the metabolism work. And they did something very simple. They looked at the date that they drew the blood, and then they went into the archives to see what the weather report was for the previous 7 days. And they looked at that and they found that the more days of sunlight there were in Oxfordshire and Laden, the better the profile was in general for those patients who had that blood drawn. So literally within a 7-day period of time, getting out into the sun and getting exposed to light can be very beneficial. Let me just also qualify really quickly here regarding this. And that is, this question is, do I need to be in direct sunlight? What about the fact that I've got skin that's very sensitive? What about the fact of skin cancer? So these are all very good concerns. Let me just flat out right tell you, is we've mentioned a couple of times that near infrared radiation can penetrate through clothes. We actually did a video on the types of clothes. Cotton is very easy to penetrate through. So it's very easy to do that. So it's possible for you to get the benefits of near infrared radiation by putting on a broad-rimmed hat, by covering up completely all of your skin with one layer of clothing, which will be enough to prevent the high ionizing radiation of ultraviolet lights, for instance, if you're concerned about that, but still allow near infrared light to come through. And if you go outside and you're in green spaces, and you're fully clothed with a hat on, and you're not getting the full onset of that light from the sun, you're still going to get way more near infrared radiation than you would be if you were inside your home.
That's incredible. And thank you so much for explaining that to us so eloquently. Dr. Schultz, you are such a wealth of information, and I know that, with medcram.com, you have a lot of different courses available for healthcare professionals. What can we look forward to from Medcram in the future?
Well, thank you. Yeah. So not only do we want to educate the public, but also healthcare providers, and not just in areas of lifestyle and health. So we also offer a huge cadre of courses, for instance, EKG courses, to show you how to read an EKG, how to read a pulmonary function test, asthma, the treatments of which. There's also a course on ultrasonography. So these are courses that are core competencies that physicians should know how to do: how to read a Chem 7, how to read a CBC blood test, when to transfuse, how do you treat high sodium, low sodium. And we've actually gotten continuing medical education units on these, so people can use their funds that they need to get continuing medical education and take these courses. And we explain it very, very clearly. So we've had physicians take these courses and rate them very highly. These are courses for nurses, nursing students, PAs, PA students, respiratory therapists. Just about any healthcare provider could benefit from these type of courses, and they're available at our website, medcram.com.
Yes, and I was going through the incredible amount of courses that you have available. And even for pharmacists, here in Canada, pharmacists are getting an expanded scope of practice. It sounds like we may be able to order labs soon. And so some of those may be even really helpful for pharmacists. So you can go check that out at medcram.com. Dr. Seheult, thank you so much for all of the information you've shared today. I'd be interested to know if you had one message that you would want to share with our audience today, what would that be?
I would say that that we have to be careful of falling into a false dichotomy where only medications work and nothing else works, or the opposite, where only things that aren't medicines work and medications don't work. I think to be a rational, efficacious healthcare provider, you have to understand when things are needed and when things are not needed. And realizing that a lot of the things that we talked about today could be very beneficial for people, but also realize that we shouldn't depend 100% on these, and that there is a role for medications, for the training that we've all done. And so knowing when to use these things and when not to use these things, I think are very, very beneficial, and really come down to the healthcare provider and the patient.
Thank you so much, Dr. Seheult, for joining us today. Thank you for just bestowing some of your incredible knowledge upon us. I think it's so important as healthcare professionals that we can really be aware of all of these, both pharmaceutical and non-pharmaceutical interventions, things that we can do to help us maintain health rather than just treat disease, right? And so I think this is just of utmost importance. You are really such a treasure. And so thank you so much for joining us today in this conversation.
Well, thank you so much for having me on. I look forward to maybe coming on again.
That would be wonderful. Thank you so much.